Limited. Endothelin receptor antagonists provided better results. The recent Portico trial, specifically designed for portopulmonary hypertension, demonstrated significant benefits in pulmonary vascular resistance as well as the 6-minute walk test with macitentan. Common drugs in this category include bosentan, ambrisentan, and macitentan. Bosentan is generally liver toxic, so it's generally avoided in patients with liver cirrhosis who have portopulmonary hypertension. So the options are ambrisentan and macitentan. While the phase 4 study and the randomized clinical trial used macitentan, in Singapore for this condition we generally use ambrisentan because it is 1/3 the price of macitentan. And we've had similar results with improvements in patients seen with this drug. While individually, phosphodiesterase 5 inhibitors and ERAs provide some benefit, combination therapy appears to be more effective. In this cohort study from France, a combination of PDE5 inhibitors and ERAs demonstrated better improvements in pulmonary vascular resistance and 6-minute walk tests. In this study, they also demonstrated with combination therapy benefits in mean pulmonary artery pressures and cardiac outputs. Finally, we'll cover transplant-related issues. While I must apologize to the organizers because the aim of this STC is not to talk about liver transplantation, we cannot touch on portopulmonary hypertension without at least discussing a little bit about transplant-related issues. So why discuss transplantation in these patients? In patients who are eligible for liver transplantation but did not undergo transplant, the prognosis was grim with a 5-year survival of less than 50%. This was driven by both the liver disease as well as the pulmonary hypertension. Prior to advances in therapy, patients transplanted for portopulmonary hypertension had poorer outcomes post-liver transplant than matched patients who did not have portopulmonary hypertension. There was a higher risk of dying within the first year post-liver transplant. And this was primarily due to right heart failure in the perioperative period due to underlying right heart dysfunction driven by the pulmonary arterial hypertension. The original studies that looked at the factors associated with mortality post-transplant in these patients identified the mean pulmonary artery pressure and the pulmonary vascular resistance as key factors associated with mortality. Recent advances have highlighted the greater significance of pulmonary vascular resistance as it correlates better with right heart function. So how do we evaluate these patients? Any patient for liver transplantation should have an echocardiogram. If the pulmonary pressures are elevated, they should be interrogated with a right heart catheterization. Based on the results of the mean pulmonary artery pressure and the pulmonary vascular resistance, the safety for transplant can be considered. Based on the mean pulmonary artery pressures as well as the pulmonary vascular resistance, the decision can be made if the patient is safe for liver transplantation or requires bridging treatment with one of the agents discussed before. Monitoring for treatment can be done with a right heart catheterization every 3 months, although sometimes more practically in patients not for transplant, this can be done every 6 months to every year depending on the severity. Once we decide to bridge a patient to transplantation with pulmonary hypertension, the targets are as follows: a mean pulmonary artery pressure of less than 35 millimeters of mercury, a pulmonary vascular resistance of less than 5 Woods units, although in some centers like mine, where we are paranoid about this condition, we aim for pulmonary vascular resistance of less than 3 Woods units. And finally, a satisfactory right ventricular function on transthoracic echocardiogram. With careful bridging with therapy, outcomes with liver transplantation are similar to patients transplanted for other reasons and exceed that of patients who do not undergo liver transplantation for this condition. In addition, in this cohort study, it was shown that all patients were able to discontinue parenteral vasomodulator therapy, and more than half the patients were able to discontinue all vasomodulator therapy totally. Despite the outcomes mentioned, transplanting these patients can be a challenge and must be done in close communication with the anesthetist and the cardiologist. Transesophageal echocardiogram should be available for intraoperative monitoring, and pulmonary vasodilators can be administered throughout the operation, especially at key points in time during reperfusion. While a lot of the data in this disease comes from the West, in the East, we tend to do more living donor liver transplantations. And sometimes, along with these, come complex outflow reconstructions that require total cross-clamp of the IVC rather than a partial cross-clamp that we see in a routine piggyback transplant. During reperfusion, this can severely affect the right heart. These need to be prepared, anticipated, and considerations for veno-venous bypass or VA ECMO at the time of surgery have to be made. As can be seen, the most critical period in the transplant surgery is during reperfusion, as this is when there is a sudden rise in the PA pressures and the venous return to the right heart. In summary, portal pulmonary hypertension is a rare yet significant complication for patients with liver cirrhosis. Differentiating the diagnosis from other causes of elevated pulmonary pressures on echocardiogram is essential to guide treatment both for the patient and for the condition. Pharmacotherapy with vasomodulator therapy may be able to sustain patients, but liver transplant appears to be the most definitive treatment options, yet must be undertaken with careful planning. With that, thank you for your attention, and I hope to see you all sometime soon, hopefully at APASL 2025.
A very good afternoon, everyone. Welcome back after lunch. Let's start our fourth session of the day, Critical Care Hepatology, Endpoints in Critical Care. For this session, it is a great pleasure to invite our experts, Professor Julia Wendell, Professor Rajendra K. Reddy. Kindly take your seats. So this session is a combination of a panel discussion followed by talks. So for the panel discussion, may I invite our esteemed moderator, Dr. Bindu N. She is the Chief Intensivist at the Department of Hepatology and Liver Transplant at Sir H.N. Reliance Foundation Hospital, Mumbai. May I also invite our panelists, Dr. Ankita Singh, Dr. Sanjeev Sehgal, Dr. Joy Varghese, and Dr. Rakhi Maiwal. Kindly take your seats. Welcome, ma'am. Hi. Welcome, sir. And welcome to our eminent panelists. So, my topic for the day is ABG, arterial blood gas analysis in patients with liver disease who are critically ill. So, the first case scenario, we will talk about a 55-year-old stable cirrhotic patient, Child-Pugh score B, who has come to the OPD. This is the acid-base status with a pH of 7.45, PCO2 of 31, a bicarbonate of 21, and a base excess of -2. And these are the investigations that we have for these patients. So, as we analyze this ABG, we realize that the patient is having a respiratory alkalosis with a normal base excess. So the clinical interpretation that we have is that of a stable cirrhotic. But when we really look at the mechanism, what is happening here is that the base excess is normal. When we look at it in a Henderson-Hasselbalch equation, where we look only at the CO2 and the bicarbonate levels. So any comments, Dr. Ankita, about why you think this compensation is happening in this patient?
So good afternoon, everybody. Good afternoon, moderators and panelists. So in stable cirrhotic patient, the overall base excess tends to remain normal, whereas a base excess subset analysis will obviously show that there are multitude of responses which are offsetting each other. So in this patient, for example, we have a normal base excess, but there is respiratory alkalosis. So there could be multiple factors which would be contributing to respiratory alkalosis. And if we could just go back and analyze the base excess, so in this case, because of
We can.
so if we have a closer look at the base excess subsets, the albumin value is +4, which would be likely contributed by hypoalbuminemia, whereas the sodium value is -3, which could be because of hyponatremia. So overall, multiple factors contributing and offsetting each other would lead to an overall normal acid-base status. And the alkalosis could be because of respiratory factors.
So ultimately,
a subset analysis is important to differentiate the etiology.
So ultimately what we see is that the patient is not completely normal from the acid-base point of view. There are so many things happening, but because of the compensation, we find that there is no apparent metabolic base disorder. So most of the time when we look at the ABG, we only look at the base excess and the pH. We do not really focus on the subsets. So sometimes we can miss subtle findings that are in the patient. So there is this approach where is the Stewart's approach where we look at the subsets and we analyze the subsets and we realize these are the things that are going on. Like you said, the plasma dilution, the chloride, albumin, lactate, unmeasured anions, all these can contribute to the fact that the patient is having some acid-base disorder. So just a short synopsis about the Stewart's formula. It is just that we look at 3 factors when we look at the Stewart's, that is the PCO2, the strong ion difference, and the albumin total. Or this is actually the unmeasured anions that are in total. These are the 3 factors that we look at in the Stewart's equation. And when we plot a Gabelgram for the same, we realize that the positive ions, that is basically determined by the sodium, and the negative, which is determined by the chloride. So ultimately, body tries to maintain its electron neutrality by balancing the cation and the anions, and they try to keep it as close to 0 as possible. But because there are some unmeasured anions, what you actually find is a strong ion difference about 40. So there are different ways of calculating the subsets like dilutional acidosis. So there are various formulas in which you can calculate the sodium imbalance, the chloride imbalance, a contribution of albumin, lactate, or other unmeasured anions to the same. Or we can just log into some of the sites like acid-based org analysis, which will give you ready-made answers. What is the acid-based pathology that is actually happening with the patient? So most of the time, our liver patients either have a dilutional acidosis or a hypoalbuminemic alkalosis or a metabolic acidosis. So coming to the second case, we have a 47-year-old patient with post-hepatic cirrhosis and large esophageal varices. And he's admitted in the ER with severe variceal bleeding. These are the investigations. So now that we know about the subset analysis, we can see that the lactate is very high. What this patient is having is lactic acidosis. So lactate is a very important component that we look at in the ICU. I think as hepatologists and gastroenterologists, everybody is very interested in lactate. Dr. Joy, you may, what is your opinion of lactate? How fond of you are of lactate?
Good afternoon. Normally, as a hepatologist, whenever we are going through the ABG, so we used to see the respiratory alkalosis. This is a normal because of the hyperventilation. Hyperventilation can occur in any liver cirrhosis due to the ascites or hydrothorax or due to the hepatic encephalopathy. The center will not activate properly, so the respiratory alkalosis are common. So at that time, usually we'll say PaCO2 will be low and the pH will be normal. Because if you see any cirrhotic patient in our OPD, normally they will have some sort of a hyperventilation, but the pH is normal, so they will not be asymptomatic. They will be asymptomatic. But this, whenever they are going to get some problem, so this case lactic acidosis. So the pH in our body is normally maintained with the two main organs, one is the kidney and the lung. And the liver plays few roles, but we all know cirrhotic patient will get the kidney issues, cirrhotic patient will get the lung issues. So we always, whenever we are reading the ABG, we have to compare with the patient symptoms. So with just one ABG with asymptomatic, we shouldn't interpret too much. That will lead a lot of complication because most of the compensatory mechanism is going on. Lactic acidosis, liver plays, we know, so the Cori cycle. So glucose from the liver, it goes to the muscle. From the muscle, glucose is converted into the pyruvate and the lactate. So that lactate again comes to the liver. The liver is normal, that lactate will get converted into the again glucose. That will be. So this is the Cori cycle. Whenever the liver disease happen, that time this Cori cycle will get disturbed. So they will give the lactic acidosis. So this is a liver disease. Sometimes even though liver is normal, sometimes they'll get a lactic acidosis due to the hypoxia, shock, another tissue ischemia happens. So yeah, they have mentioned here the hypoxia related, liver related, non-hypoxia related. So whenever the lactic acidosis, if it is a mild, as I already told, there are the compensatory mechanisms happen in our body. Either the hyperventilation, the respiratory alkalosis will try to compensate. Normally in the previous slide, there are the few points was there. The albumin level, normally all our liver patients have the low albumin. Albumin is a weak acid. So whenever albuminemia, low albumin is there, they will have the metabolic alkalosis. So what are this I wish to, because here our audience are gastro, not intensivist. So what our Raki is there, we will look into that respiratory alkalosis due to hyperventilation in cirrhosis. We will look into that metabolic acidosis either due to liver failure or sepsis or shock. We will look into that metabolic alkalosis due to the severe hypoalbuminemia. And the third, as we are giving lactulose over, and that will cause diarrhea, bicarbonate loss, that also will cause metabolic alkalosis. And urea cycle also will get disturbed in liver disease. So we know ammonium is converted to the urea in the normal liver. That time it will utilize the bicarbonate. So whenever the hyperammonemia is there, that time bicarbonate is underutilized. That also will cause metabolic alkalosis. So it is totally a complex phenomenon. So respiratory alkalosis happening in liver disease, metabolic alkalosis due to hypoalbuminemia, and the encephalopathy causes the metabolic alkalosis. Then albumin related alkalosis. So and the urea cycle defect. And along with that, if the patient have HRS, that will alter the again. So if the patient had a superadded infection, so the ABG wise, usually our setup, our intensives will take care of the analysis and to go ahead for the how to correct whether it's really required for correction or not required, and they will, based on that, they will manage. So the previous slide, because why I explained, because as we rushed through that all the slides, something how to interpret if the patient had the complication of cirrhosis we have to manage. Dr. Raki is our intensivist. Any few points, if you can comment on it.
Yeah, I think so. You've covered a lot. In this context, when you're dealing with a lactate and acid, means lactic acidosis, this is the most serious thing in any liver patient. So it is not just simple metabolic acidosis. This acidosis is also associated with impaired tissue perfusion or hypoxia, whatever. At the tissue level, there is hypoxia. So all attempts should be made to achieve the clearance of this lactate, and therefore it becomes very important because one is impaired liver, which is not clearing the lactate. But what organs produce, what organs clear, what could be the underlying factors, and looking at the clearances, and we should be targeting at the clearance of the lactate in these patients, because this is a very, very grave scenario, and these outcomes can rapidly, these patients may deteriorate. So lactates are something which are very important in the ICU. And clearing the lactate is something which should be the goal. And you should be able to achieve a clearance of around 25 to 30% at the 6 hours time frame. So that is where you are. So you know that you've done, even though the peak levels were high. So clearance is one thing which is important. And for that, you need to look at the different factors, whatever possible things can drive that lactate, drugs like metformin. So all those have to be very carefully assessed, because your strategies will all depend on the etiology.
So the problem with lactate is that it is multifactorial. It is produced by it is cleared by the liver. It can be produced by tissue hypoxia. So there are so many factors which contribute to increased lactate. So mainly, I think looking at the patient in a holistic manner, not just focusing on the liver, that would also be very important in this context. Okay, we come to the third case. 46-year-old cirrhotic patient with sepsis due to spontaneous bacterial peritonitis. The patient is treated at a normal ward and received 4 liters of normal saline because of hypotension. So we did a ABG for the patient, and the patient is having a pH of 7.3 with a bicarb of 14 and chloride of 105. Lactate is 1.4. They have analyzed the subsets for us, and there we can find that the base excess of for chloride is about -10. So this is classically like hyperchloremic acidosis, which happens when we do fast fluid resuscitation. So the controversy here is about what type of fluid would you like to use in a patient with liver disease in such a scenario.
Here it clearly shows metabolic acidosis because the pH is less than 7.4. Please previous one. So there is a pH 7.3, acidosis shows, and the bicarbonate normal will be 24, here 14. So the metabolic acidosis. So to compensate, if you see the PCO2 normally will be 35 to 45, there is a washout. So compensating is a respiratory alkalosis. So metabolic acidosis with the respiratory alkalosis. Now the base deficit. So it goes to -11. Normally we can keep -3 to +3. That time we no need to correct. Whenever it goes to the less than -3, so we have to see the deficit. So -11 and the -3 difference is 8 millimoles. So 1 liter of blood, we have to give 8 millimole of the bicarbonate to correct the acidosis. So normally we have a 5 liter of blood. So 8 millimoles per liter means 5 liter, we have to give 40 millimole of bicarbonate. Normally 1 ampule of the bicarbonate solution 50 ml. So we can give up to 1 ampule of bicarbonate to correct this is the symptom, that the value related correction. But we have to look into the already mentioned the sepsis, SBP and other things. We have to correct the proper antibiotics and other things. So that's where we have to look into that. And the patient received the normal saline. So normally the chloride, we are giving hyperchloremic will cause whenever the chloride level increases, the bicarbonate loss will be there through kidney. So that also will cause hyperchloremic acidosis. So here the chloride level is 105. Normally it will be around 95. So this all hydrogenic. As we have given more and more normal saline, that time apart from the sepsis induced metabolic acidosis, so we also cause. So that's why we have to look into that ABG. And we have to manage.
Yeah, so the thing is probably we should not be infusing such high chloride solutions into the patient. Maybe we should think about balanced salt solutions, as Dr. Ankita was telling me just before. And I think it is not just about what fluid to use, it is how much fluid to use. We do have methods in which we can monitor the fluid responsiveness of the patient. Currently, we use focus and we find out how deficient the fluid is, how much fluid can be given, and a restricted fluid strategy in this group of patients would be better than just infusing 4 liters of fluid just because the patient is in shock. Then there are other agents that we are supposed to add, like the vasopressors, and according to the various shock studies, we have the septic shock trials which are advised, which we should follow. That is madam.
The field has now moved, and I think so from all ICUs, even if the volume of fluid required is less.
Yes.
Liver patients, we've moved to a balanced crystalloid approach, and
Yes.
I think so all the intensive care units are now moved from normal saline to the balanced crystalloids. And only in the settings where we are dealing with diuretic-induced hypovolemic hyponatremia, where you want to actually improve the sodium levels, is where we are actually now using normal saline. And the message again, giving 4 liters and not monitoring anything of what targets and how we are monitoring, how much fluid, what fluid, all that is very important in the context. And each 3 hours assessment of fluid status should be done so that we don't land up with such grave complications. Because overall, this has a very worse outcomes on kidneys, coagulation, and all this is associated with increased bacterial translocation, second infections, prolonged hospital and ICU stays. So all this related to your overall outcomes in the ICU.
We come to the final case of the day. It's a 54-year-old patient, non-cirrhotic, presenting with actually jaundice, transaminitis, and coagulopathy after initiation of ATT, antituberculous treatment. And he developed encephalopathy on day 2 of admission. So this is the acid-base status of this patient. So we can see that the pH is 7.4 and the base excess is -5 with a lactate of 3 and the ammonia is around 150. So, and an INR is 4. So we would come to a diagnosis of acute liver failure in this situation. And what I would like to ask you about is about ammonia and your takes on non-hepatic causes of hyperammonemia, and whether we should use ammonia as a prognostic marker in patients with chronic liver disease, and why we are not using it in the management of hepatic encephalopathy.
I think that's very like an important issue we have picked up, because we have sort of been grown with an idea that ammonia is liver failure, ALF, and that has been, there. I mean, we have what excellent, studies. I mean, Professor Benden has been, one of the stellar person on this. Dr. Acharya has published, and we know that like different cutoffs have been explained. That higher the ammonia, the more the mortality and morbidity in ALF patients. Cutoffs are 124, 150, 160, whatever it is. I think even in ACLF, Raki, some people have shown that 60, 70 is a cutoff where beyond which the mortality is more. So, question is that there are different non-liver sources of ammonia as well, which we have to understand. Of course, in this clinical setting, I won't really worry about that. But otherwise, one can have renal failure, which can cause urea defect. You can have, drugs which can cause hyperammonemia, some infections in gut, which can, which are ammonia-producing organisms, some urea cycle defects, I guess. So there are other causes, one should be aware of that. But in the clinical setting like this, in a setting like this, I think, well, I would take ammonia as, primarily because of liver failure only. We do actually take this seriously in our prognostication scores when we try and select them for, whether we should go for transplant or not. But simply lowering ammonia does not change the prognosis that I have seen. That is for sure. So our aim should be more of a clinical picture, the clotting, the encephalopathy grade and all, everything together. And then, we can incorporate this in a score and then come say, okay, fine, this patient doesn't look to be doing well and will not survive. And then we go. So that's why I look at it clinically.
So, so is there any cutoff where you use, what is your cutoff for ammonia in acute liver failure to start CRRT?
See, our published literature, which our Indian data from AIMS, I think Dr. Acharya has published what to 124 or so, I suppose. And then, like some fever has 132. But I think that if I see my practice in ICU, I don't know what Joy feels. Most of all my patients have 150, 200, 300. I had a boy recently who had 700 ammonia, 770. And then we did CRT for the patient actually. So I have seen that most if they have genuine ALF, hepatitis A is now the commonest which I'm seeing in the practice. And they have always invariably have other complications. They have liver failure with renal failure, GCP deficiency, rhabdomyolysis. So ammonia really shoot out very high. So I think those cutoffs, I perceive that, they are reasonably low actually in our setting to consider them for a prognostication. Maybe Professor Venden, she's a master of that. She can add on in her comments later on.
All right. Thank you. Thank you so much. This was an exceptional talk. Thank you, moderators. Thank you, panelists. We'll have the questions after the talks. So for the next segment, may I invite our moderators, Dr. Mukta Bapat, Dr. Sudhiranjan Das, Dr. Manoj K. Sahu. The next topic is use of albumin in the ICU by Dr. Shivsari. Unfortunately, sir couldn't be here in person today, but he has given us the opportunity to listen to a pre-recorded version of his talk. So I'll request the AV team to play the version. Thank you.
Greetings from ILBS and thanks to Dr. Akash and the organizing team. I'll share in next few minutes about albumin in ICU, the yeas and the nays. I have nothing to disclose. Human serum albumin is the native albumin, while human albumin solutions, HAS, is a drug. In liver ICU, is it good or bad? Dominantly, it is good. I would like to share with you that hepatocytes make albumin, which is distributed both in the extravascular and the intravascular compartment, which is the one which maintains the oncotic pressure. I will discuss about the functions, structural alterations in liver disease. The ABC of albumin actions can be very well read in this review, but importantly for us, that in the ICU, it has a positive effect on the heart, capillary integrity, immunity. It works to maintain or retain the osmotic pressure and also can bind and has anticoagulant activities. In cirrhosis, the albumin levels go down because of cell loss or what the doctors do. It can increase several folds in healthy but not in a cirrhotic population. I'm showing you this because albumin is modified in cirrhosis, different forms occur, and every liver disease has a separate albuminome. It is separate for ACLF, separate for ALF as shown very recently, and separate for decompensated cirrhosis. So every patient does not require replenishing albumin. A dominant number may require replacement of albumin. The three forms of albumin as by HPLC compared to the Baxter albumin you give or a healthy person's albumin, you have dominantly human mercaptoalbumin. This is the dominant 70 to 80%. And the HNA1 non-mercaptan, which is a reducible albumin, and non-mercaptan non-reducible C34 position. All the reactive oxygen species, they are bound here in the 34 position. That is the beauty of HMA. Now, in patients with alcoholic cirrhosis or severe hepatitis, HNA1 or HNA2 levels increase. In fact, if patients with ACLF, if the HNA2 level, which is the most toxic, increase to more than 12% of the total, high 30-day mortality has been described. The second important part you have to remember is that in patients with ACLF dominantly with high bilirubin levels, this property of the albumin which binds one bilirubin molecule to one albumin molecule is overpowered, and three molecules of bilirubin are binding into the albumin. So here you can see that instead of one, three molecules of bilirubin will bind. Now this albumin now becomes useless. It is a hyperbilirubination of human serum albumin. which occurs. So your endogenous albumin within the patient is generally non-functional. Let's look at the role of albumin in ICU in maintaining oncotic pressure or reverse shock. So in these patients, first let's understand the difference between normal and cirrhotic patient. How is the blood volume distributed? Compared to normal, in cirrhosis, the abdomen has much more, the splanchnic circulation has much more blood volume. This is an important diagram for you to understand that as the severity of liver disease increases, the arterial compliance of the patient increases. It's not decreased, means the artery volume, the diameter is small, but the compliance is increased. Let me show you further. Here is a child A who has a good mean arterial pressure compared to a child C. Now, if you give pre and post, this is pre and this is post, the expansion of the artery is not too much. But in child C, the expansion of the artery is a lot. So you keep on pumping the fluid, but the pressure will not rise. In fact, compared to this, the pressure remains like this. Let's go further to understand. Now, this is central blood volume, which is in the vessels, and this is non-central blood volume. Compared to patients, this is before and after. In a child C, you are pumping fluids, but your central blood volume does not increase. The arteries are expanding and the non-central blood volume increases. What does it mean? That you may not be able to raise your pressures, but you may flood your lungs and you have a positive balance in the body. Based on these concepts, we thought let's compare crystalloids to colloids, and this was done comparing saline with a 5% albumin solution. Now, a patient who has sepsis and hypotension already has a low blood pressure and there is a high portal pressure. So decreased SVR further worsens in sepsis, and this is a vicious cycle. What is our aim is to have in 3 hours time maintain the mean arterial pressure and clear the lactate, and hemodynamic homeostasis, organ perfusion should help survival. Now the difference between the two types, colloids and crystalloids. When you give colloids, they are hardly retained intravascularly and they will come out. Colloids will retain in the volume in the lumen, and they will try to stabilize the glycocalyx, and the intravascular compartment is stronger, the pressures increase. On the other hand, the crystalloids are low cost, but they will have quick extravasation, and therefore we try and give colloids, but they may have risk. And the transcapillary escape rate increases 300% in sepsis. So remember, if you give albumin, it will escape into the extravascular tissue at the cost of raising the blood pressure. Let's go further to see. So in this FRISK protocol, which was part of Dr. Abe's thesis, albumin 154, saline in 154. Within 1 hour, the hypotension and shock was reversed much better in those who received albumin, and it was sustained for 3 hours time. Within the ICU admissions, albumin increased survival compared to saline. So I will summarize this part. In the fluid resuscitation in severely septic cirrhotic patients, the 5% albumin reverses sepsis and hypotension better than saline, and also it improves heart rate, reduces lactate, and the short-term survival in ICU is better. We went to the second protocol, plasma light versus 20% albumin, to see if higher dose can help better. And this was published by my colleague Dr. Rakhi in the ELPS trial. In the ELPS trial, plasma light was compared to 20% albumin, and the benefits were faster attainment of mean arterial pressure, faster decline in arterial lactate, reduced need for dialysis, longer time for dialysis initiation, and however, there was no survival benefit, but at the cost of higher incidence of pulmonary complications. You have to be very cautious in your ICU, like Rakhi and the team, to see that complications don't occur. What ELPS trial showed us in 3 hours time, 20% albumin was better than plasma light in reversing shock. However, as I'll show you later, there are several problems with this. In ELPS trial, pulmonary edema was seen in 12%, and in addition, several other complications were reported. And in 11 patients, the albumin had to be discontinued. The second area, patient has tense abdomen, ascites, and we need to do tapping. This trial was done by Dr. Vinod Arora, and he showed, especially in sick ACLF patients, if you have patients and do tapping, you should better do modest volume paracentesis, that is, tapping 3 to 4 liters and not 5 liters. Even if you do modest volume paracentesis, hyponatremia, HE, and acute kidney injury develops in about 60% or so. But if you give albumin, this is reduced substantially. So there is an advantage of giving albumin while tapping for even 3 liters. For cirrhosis, all the guidelines are above 5 liters LVP, but ACLF, modest volume paracentesis, should have albumin. The other advantages could be for infections and HE. There is limited data. This is a basic diagram, but I want you to understand it. Now, in a patient, these are the monocytes which are seen here in the cells. In patients who have got high levels of prostaglandin E2, this is PGE2. Now, PGE2, if the albumin levels are low, is binding the TNF alpha. If the PGE2 is not bound to monocyte, the PGE2 is in circulation and it will bind to TNF alpha. If the albumin levels are increased, as you are showing here, the albumin is more, it is binding PGE2. Albumin binds to PGE2. If it binds to PGE2, your TNF alpha is free and that will kill the bacteria. So this was the basis. However, it has not been found to be useful in ICU setting. And if the albumin levels go up, human serum albumin levels, the lipid mediator inflammatory responses are reduced. So there is theoretical basis of giving albumin by improving monocyte function and improving lipid membranes, but its use in ICU has not been shown. In this study, elegant study by Professor Bajaj, he has in the HEAL study in minimal hepatic encephalopathy compared to placebo, 25% albumin improved the minimal hepatic encephalopathy, it was reversed, psychosocial, endothelial dysfunction, they all were there, but they came back once the albumin was discontinued. Whether it is useful in ICU and in HE remains to be seen. Lot of work to be done. In this review article, which has been highly cited, we had discussed nearly 4 years ago that albumin can be good, but there are potential adverse effects and there should be judicious use of human albumin solutions. What could be the adverse effects? So there could be general dermatological, cardiovascular, especially pulmonary edema, fluid overload, and hypo or hypertension. Respiratory, I'll come to it again. There is immense knowledge, and now Omkar's thesis has also shown that albumin can cause anticoagulant effects and platelet lowering property. It is actually can predispose to bleeding. GI bleeds can occur because of increased pressure, and also patients can have neurological complications. And this is coming back to the study, the 20% albumin study. This red line is plasma light and the blue is 20% albumin. So CVP is better. IVC in these patients, as you can see, with increase. So when you are giving albumin, you are actually increasing your IVC. It is helpful for pressure maintenance, but should also be careful monitor to prevent overload. And you can see the effect on lung. The PF ratios after a few hours, 3 hours, 4 hours of 20% albumin, they worsen, they lower down on albumin 20%. So remember, we use it with great caution. So this is a crux of the whole message of good and bad of albumin. Now, what albumin does is increases the preload. The preload on the heart, and that helps in patients to improve cardiac output. But very often, we are giving in addition vasopressin or terlipressin, which is constricting the splanchnic vascular system. So you are increasing preload and you are preventing the blood to come out, and you have an increased afterload. So the two together will cause a pulmonary hydrostatic pressure to go up, and this leads to pulmonary edema. So remember, if you are using any of the vasopressors, please be very careful in giving albumin. Cirrhotic patients not only will have this kind of overload hydrostatic pulmonary edema, but they have nearly 50% non-hydrostatic pulmonary edema when they are in the ICU due to poor cardiac function. So adding albumin can worsen these, and this is from the best group, Cardinance group, showing this data. We had shown earlier that in ACLF, albumin has changed. This is modified albumin, which is very, very injurious to the innate immune cells. Adaptive immunity goes down. The nitrosoalbumin, the nitric oxide is bound, and this is a vasodilatory, and also platelets functions go down. As I showed you, HNA1, HNA2 go up, which are very toxic. Ischemia modified albumin increases. So all these albumins are circulating. This is your endogenous, not exogenous. Now if you give albumin infusion, there is limited data to say that these functions are reversed. So in my opinion, rationale is more for removing albumin in patients who are in critical care in ICU, and just not keep on replacing albumin, because you will add more hyperoxidized, dysfunctional and toxic albumin, which cannot be cleared by a sick ICU patient. This is to show you a beautiful, simple study. Midodrine can be an alternative to albumin in preventing PICD. All the plasma renin, create, sodium, MAP, all of these were equally well done by midodrine administration than albumin. This is not ICU, but just to tell you. But you see the cost. The difference in the cost is nearly 6 times more. So can we not have simple and safer alternatives to albumin? Midodrine has not been tried in ICU, and maybe it is time to do that. So my carry home message, friends, is be judicious and cautious in giving albumin in ICU for liver diseases. My recommendation is only for 2 groups: 5% albumin for 3 hours in septic shock, not 20%, or with paracentesis, if you are doing, you can give albumin. Else, other conditions, use your judgment, because it may harm. With that, I invite all of you to APASL 2025 in Beijing from March 27 to 31st. Thank you for your kind attention.
Go to the second lecture. I invite Dr. Rakhi. Dr. Rakhi Mangal. She'll talk to us on indications to terminate CRRT with improvement or worsening of the patient. Dr. Rakhi.
Thank you, Dr. Akash, for inviting me and giving me a difficult topic which made me think. And also I feel this is an area where we need to see and generate some data, because there is absolutely no evidence in this context when it comes to liver patients. But I'll try to show you some perspectives how we take these decisions of discontinuing continuous renal replacement therapy. So this is going to be the outline of my talk. I'll talk about firstly why we are using, so what are the common indications and expanding indications of using this renal support in our patients with liver disease, the protocols of discontinuation with respect to definitive options that have been considered, futility and renal recovery. So this is the basic spectrum that we see in all our liver ICU. So we see patients with decompensated cirrhosis who have sepsis-related organ dysfunctions and failures. We have acute and chronic liver failure, and we have acute liver failure. Acute liver failure is a separate set of patients, and we use CRRT for the management of cerebral edema, initiating it early. The evidence is very clear. So once the cerebral edema improves, the patient improves, we can discontinue. But the challenge is, and the focus of my talk will be in the context of decompensated cirrhosis and in patients with acute and chronic liver failure. So now CRRT is no more just a renal replacement therapy. So obviously we need it for managing the renal dysfunction, for the management of different electrolyte abnormalities, metabolic abnormalities, volume control. But also this is an important form of therapy for management of systemic inflammation, which is driven by cytokines due to inflammation or infection, clearance of the small or the middle molecules, management of cerebral edema, which we see particularly in acute liver failure, and also some patients with acute and chronic liver failure, and also for management of cytokine-driven organ dysfunctions of failure, particularly both pulmonary and extrapulmonary ARDS and hemodynamics in vasoplegic shock. Now the potential for reversibility, so whenever you're using for the indication, that will determine when do you stop. So when you're using your patients for management of septic shock, once the shock is better in context of decompensated cirrhosis, we start looking at whether we can start discontinuing CRRT, and that is what we'll be discussing. In patients with acute and chronic liver failure, more often these patients have to be put on CRRT, if at all, and then they are discontinued only if there is a reversal, not only of renal failure, but also of liver failure, or they have to be bridged to a definitive option like a liver transplant. So these are the well-known indications, both absolute and relative, which all of us know. The renal indications are very clear to this audience and there is no debate. But more often now, what we need to understand is when we're using CRRT, a kidney in the patients of a critically ill liver patient is no more occurring in isolation. And there is an intense organ crosstalk. So whenever there is AKI, even if the AKI severity is less, you may have other organs which are differentially more involved. So you may have an ARDS, and which is driving in hypoxia and renal dysfunction, which is mild. You may have a refractory shock. You may have patients who have tense abdomen, hypertension, or capillary leak syndrome. So cytokine release syndrome, which is associated with a lot of organ dysfunction, particularly occurs in the context of infection or inflammation in the context of ACLF. This is something which causes rapid onset organ failures, and CRRT is one such therapy which can actually ameliorate the cytokine storm and improve all the function of all the organs, not just the kidneys. So let's look at the burden of AKI in patients who are admitted to the intensive care unit. And in this paper from our center, we propose two concepts. One is 80% of these patients who come to the ICU with cirrhosis, they have renal dysfunction of some sort. 55%, almost more than one half, will have progression, which will be to the extent you may require almost 30 to 40% of these progressive AKIs go on to the requirement of renal replacement therapy. And what drives the persistence or the progression of organ dysfunction was the failure of the other organs, the extrahepatic organ failures, the degree of systemic inflammation, high serum bilirubin, and infections due to multi-drug resistant organisms, because you need nephrotoxic antibiotics for managing these difficult to treat infections. When you look at acute and chronic liver failure, the burden is even more. And if you see stage 3 AKI in ACLF, which is the more common phenotype, and rapidly these patients of ACLF have a progressive AKI, and only 17 to 20% of these patients will be managed by the routine therapies of albumin or your terlipressin, and most of them will have some
structural phenotype, and somewhere in the illness, they will go on to the requirement of extracorporeal liver support, and CRRT is the safest form of therapy which is offered for these patients. Now, when you compare the two strategies, and this was a randomized controlled trial, very difficult study. We enrolled 30 patients in each group almost, comparing CRRT and intermittent dialysis, because people think that SLED, which is a hybrid modality of intermittent dialysis, can be safely offered to patients of cirrhosis with shock. But let's see the results. Very severe intradialytic hypertension if they have mild hemodynamic instability. Clearly, this population gets into hypertension with the initiation of dialysis. There was no differences in the renal recovery rate and also in the transplant, the patients being made eligible for liver transplant or mortality. But what was different, again, was the differences in the improvement in the organ failure scores as well as the liver severity score. So again, expanding on the benefits of CRRT beyond just a renal replacement. So when you're doing in shock patients, the additional benefits that you see when we compare the pro-inflammatory cytokines, a significant reduction in the C-reactive protein and ferritin was seen with CRRT therapy. However, it was not seen with your SLED. So what are the protocols for weaning? So when you're considering CRRT in patients with ACLF and decompensated cirrhosis, one is clinical improvement, the other is we are bridging to a liver transplant, and the third very important, which should not be forgotten and we'll be discussing, is futility, and where you're getting adverse events requiring discontinuation. So what do the guidelines guide us in this aspect? So the Kidney Disease Improving Global Outcome Criteria guidelines, which were published in 2012 on renal replacement therapy, suggest that renal replacement therapy should be discontinued when the intrinsic kidney function has recovered to the point that it is adequate enough to meet the patient's needs, or because RRT is no longer consistent with the goals of care. So let's look at the data for liver transplant. This is a very elegant study, again from the Canonic database, and they looked at the RRT outcomes in patients of ACLF. They had very good outcomes even being transplanted with ACLF grade 3, and this is not a contraindication. However, the use of RRT in the pre-transplant period was identified as an independent predictor of worse post-transplant outcomes. So again, what set of patients should be considered for a liver transplant when they're on renal replacement therapy? We need to generate some prospective data. What is the kidney recovery rates? What is the role of biomarkers in this area is not known. So let's look at the data from the general critically ill population. So we are very familiar that whenever we are planning to discontinue CRRT, the most important organ that we're looking is the renal recovery. And how do we assess the renal recovery? The one is to look at the improvement in the urine output. So when you discontinue CRRT, you see that the patient has started to have some urine output. What other parameters has been seen in these multicentric trials or studies, prospective studies, is the creatinine clearance rates. We can look at the creatinine ratio, that is the decline in the serum creatinine on therapy to almost like a stage 1 AKI. Improvement in the SOFA scores, so the organ failure or the indication for which the CRRT was given, a negative fluid balance, a shorter duration of therapy. So patients who have required a short therapy are more easily to be weaned off from the CRRT. And then you look at the recent systematic review and meta-analysis where they included 23 studies looking at a large number of variables, both biomarkers and also the clinical parameters. What was the most important factor which was identified was the improvement in urine output with a very good sensitivity and specificity of about more than 80%. So urine output is one factor which can tell us that we can start considering the protocols of weaning. And why is it important? And we propose clearly that in the ICU patients, no longer we should be going by creatinine or urea measurements. Urine output combined with acid-base abnormalities is something which will govern the outcomes. This precedes the changes. It helps us in determining how the patients will respond and how can we wean off these modalities of renal support. And therefore, the APASL guidelines also, we have tried to propose, we need to validate this, that stage 3 AKI, which we very often seen in these patients, very high creatinine levels. But again, we see two sets of patients, one who's oliguric and the other who's non-oliguric. And we clearly believe there is a natural cause of these patients is different, and the response to the different modalities will also be different. And this is where we showed that in this randomized control trial, that if you start early CRRT before the patient has developed oliguria or severe hemodynamic collapse, within the first 6 to 24 hours of initial fluid resuscitation in ACLF patients with stage 3 AKI, there are better outcomes, not with respect to improving their overall survival, but yes, there is improvement in the hemodynamics, renal recovery, which again makes these patients eligible for a liver transplant and these patients get that window for liver transplant. And when we looked at particularly at the predictors of renal recovery in this set of patients from this study, where we included 100 patients, we found that absence of fluid overload. So volume status is very important, and that is why we again and again emphasizing how judicious we need to be with our volume control, the reversal of shock on renal replacement therapy, and early initiation of CRRT, as well as oliguria before we started the therapy. So all these parameters were determining improved outcomes and renal recovery in this set of patients. Response to loop diuretics. Most of us are very fond of giving loop diuretics to improve the urine output. So this is one strategy which has been again studied. When you're managing your patient, you feel the hemodynamics have improved and you're planning to wean off, but the patient is still oliguric. You may try a small dose of loop diuretics to assess the proximal tubular function, because if the patient has response to the loop diuretics, that it itself is a marker that the patient has preservation of the tubule function, the collecting ducts, and the thick ascending limb of the loop of Henle, where the loop diuretics basically act. And this also ensures there is no impairment of the blood flow to the kidneys. So all these factors can tell us whether we can start de-escalating CRRT in our patients and keeping it from a continuous to maybe switching it to an intermittent mode of dialysis. Can we use biomarkers in this context and to understand which patients have achieved renal recovery? And again, in the non-liver patients, there are different biomarkers, cystatin C as a measurement of glomerular function, NGAL, urine IL-18, inflammatory cytokines, markers of tubular repair like osteopontin was studied. And I just want to highlight what is interesting is even when you look at biomarkers, so in this particular study, they showed that it was not urine NGAL when they compared NT-proBNP and urine NGAL. Between the two biomarkers, NT-proBNP was identified as a better marker of overall renal recovery or the weaning protocols for CRRT. In the context of HRS, AKI and ACLF, we've shown that a low urine NGAL and lower arterial lactate can determine AKI reversal. But what about patients who are on dialysis? So again, I go back to this study, the CRRT, which we did as an early versus late initiation. We looked at different biomarkers of tubular injury, urine NGAL, renin, the kidney injury molecule 1 and osteopontin. But what we see here, interestingly, in a small set of patients where we did pre and post after 24 hours of initiation of CRRT, these biomarkers were able to identify non-responders. That is, patients were not recovering, but they were not distinctly different between the patients who were recovering. So what biomarkers could be important? The markers of endothelial function, which we studied here, interestingly, ADAM-TS13 and von Willebrand factor, which is a marker of endothelial function, was shown to be a significant marker to suggest renal recovery. You can also look at the urine microscopy if you do not have biomarkers, and we showed again that how beautifully you can see disappearance of granular cast and tubule epithelial cells in patients who are recovering for a damaged kidney. We can step down if the patient has achieved a hemodynamic response but no renal recovery. We can go, and in this trial in the septic shock population, we showed that effectively 10 to 15% of the patients can be stepped down from a CRRT to an intermittent mode or a SLED. So not in the initial phase, but in the de-escalating phase, a SLED could be very useful in these patients, and it also reduces the cost of care. Futility is one important area, and obviously we should try to wean off our patients from the CRRT, because futility is also very important and we should not just keep prolonging their care. And how do we assess that? It is not the models or the numbers before starting the CRRT, but it is after the initiation of CRRT, what is the recovery with respect to the CLIF-C ACLF? That is, the scores above at 24 hours and 48 hours above 59 and 62.5, as was seen in this particular study, was shown to determine worse outcomes. So scores after we have started this therapy is important surrogate for telling us whether the patient is futile. Also, if the patient has been put on a CRRT with 5 organ failures and is not showing in clinical improvement at 48 hours, these are the patients who should be considered for futility of the ICU care. Now, when you look at the coagulation assessment, and this is very, again, interesting data of ROTEM, which we did pre and post CRRT and intermittent dialysis. And what is interesting here, irrespective of the obvious clinical bleeding, almost 90% of these patients will develop some form of coagulation abnormalities. So again, coagulation, the worsening of the lactate or the acid base or whatever indication you've done CRRT is not showing improvement is another indication to stop CRRT. And this is the algorithm, and this is my final slide, just to suggest that we have to look at the goals of care, look at the renal recovery, try to aim with the help of biomarkers and understanding the dynamics of the patient, consider for definitive therapies early on once the patient has achieved the targets, and also consider futility and not prolong the care of these patients in the ICU. Thank you.
Thank you, ma'am. That was a very enriching class. Now we have 5 minutes for questions, if any.
So I was wondering if we should wrap up this session here and take some questions, and then go with the follow-up session. Is that right? So, Raki, I guess you can sit down. So Dr. Wendon and I will kind of alternate in terms of wrap-up.
I think, first of all, to thank all of the speakers and contributors for a fantastic series of presentations. Really stimulating, really great, and I hope you'll have questions from the floor as well. What did I hear in the first presentation? Really the complexity of acid base. You can't look at one parameter, and you've got to be at the patient's bedside to assess things. The importance of acidosis, looking at the Stewart equation, making sure you consider all of the parameters. That lactate is actually quite a slow responder in terms of interventions. Don't always think fluid, sometimes a bit, not too much. Always look at your chloride and your sodium before you choose your fluid. Probably one of the most difficult things any of us always do. Think about aerobic accelerated glycolysis as a cause for lactate. It doesn't always mean you need fluid. The role of ammonia we also heard about, important in all of this towards the end of the presentations. How do we measure it? Probably there is vast variation. We know about the variation in INR, the variation in ammonia as a measure is probably even greater. So we need to be cautious about that. We know that it's a marker in acute liver failure of cerebral edema, but that's just part of a composite severity score. And in acute on chronic liver disease, a different ballpark. So I'm now going to hand over to my colleague.
Thanks. So I'm going to summarize the talk given by Shiv on albumin. So as we all recognize, albumin is used in the unit and outside of the unit. And I must say, even at this stage, it's been a bit of a conundrum for me as to where the benefits are of albumin and where it might be detrimental. So I've heard the good and the bad when albumin is used in the unit particularly. He's talked about the theoretical advantages or roles for albumin, the ABCs of albumin, talked about the bad albumin, the various fractions of albumin, and of course also pointed out some of the challenges when used ubiquitously with regard to pulmonary complications, while there might be benefit. And then he left us with the recommendation that maybe 5% albumin can be used in septic shock for about 3 hours. So having said that, apart from what we've traditionally used albumin for, either in IC or outside when we did paracentesis to prevent paracentesis-induced circulatory disturbance, and also in the context of spontaneous bacterial peritonitis to prevent acute kidney injury and decrease mortality, we're still struggling a little bit to kind of come up with some precise recommendations on the use of albumin, although we seem like we have made some progress, particularly in the context of sepsis. There might be a role for 5% albumin as opposed to 20% albumin, which might lead to pulmonary complications. To add to the conundrum, we've been struggling with the role of albumin as an outpatient to see if it would decrease complications related to advanced liver disease and also decrease mortality. As you all know, there have been studies that have gone back and forth in terms of their benefit. But the more recent trial called the Preciosa trial, which was eagerly awaited and anticipated, where a randomized trial was done giving IV albumin 20% as an outpatient versus standard of care, turned out to be a negative study. So the one-year transplant-free survival was similar in both cohorts. So it didn't meet its primary endpoint, although you look at the secondary endpoint, there was a low rate of complications related to the albumin infusion. So from my perspective, it's great. We're making some progress, but still we do have a long way to go. And considering the cost of albumin, we really need to be kind of judicious in our use of albumin. That's a message I derive from this presentation.
Thank you. And now moving on to our excellent last talk, and I think this really is an interesting point of clinical decision making. The indications for renal replacement therapy, as written in most guidance, we have to soften a bit for our patients with liver disease. All of us probably think that earlier is somewhat better, although the evidence in the general literature has shown doesn't support that. But in fact, the early data that hopefully will be published soon may allow us that leeway. What sort of therapy should we use? Well, I think over the last 20 to 30 years, most of us have felt that intermittent modes of renal replacement therapy are not good news for sick patients. And I think the data increasingly shows that. The flip side of that, of course, is we must be aware both of cost and sustainability. The green agenda, the cost of fluids, the transport of fluids, we need to understand when to switch from continuous renal replacement therapy to an intermittent mode, such as slow hemodialysis and SLED modalities. And that will allow us to offer the best for our patients, the best in terms of value-based healthcare, and hopefully also the best for the planet. And I think that's where we should be driving forward now. I would say, and it was alluded to in the presentation also, that one of the risks of having both liver failure and kidney failure is their synergistic impact on both your hemodynamics and your neurological condition. So if you do dialysis and you wait for the ureas to hit 20, 25, you will end up with a really sick patient who will then have complications. So more frequent, even if it's intermittent, always gentle. When to stop when you're running a renal replacement therapy, I think is something none of us yet know. The biomarkers provide a bit of guidance, but they're really not spot on yet. What do most of us do probably in our clinical practice is we see if the patient's passing urine. We give them a filter holiday for 24 hours to facilitate rehabilitation and getting out of bed. And if you see a bit of urine, you might then do a frusemide challenge test and stay off the filter for a bit longer. If their hemodynamics are good, then you might move to SLED. But to write arbitrary guidelines is difficult. To provide guidance is good. I always view it as guidance rather than policy. is how I would summarize where we are there.
Thanks. So we'll have some questions, if there are any from the audience. While someone is thinking of a question, in fact, we should have the other two speakers up here. Other speakers, no? All right, well, Rocky, you'll have to take on all the questions then. So, okay, I have a question for you, actually, a specific question. So, in these patients who present with ACLF, there's obviously a kidney injury in a fair number of those. And you put them on CRRT at a certain stage. And then they might get to a certain stage of improvement, and then they go for a liver transplant. So while we look at survival, I don't think survival is the only endpoint we need to look at, right? So we need to look at evolution to chronic renal failure. How many go on to dialysis? How many end up with a kidney transplant at 1 year, 3 years? So do you have any sense? So what I see is that you go in bad, you end up bad. You know, you've had kidney issues, you could get a creatinine down to 2 and the liver gets offered. All right, get a transplant. You take them into transplant. Fair number of times, these people end up with CKD in a short period of time. And if they're not rescued by a kidney transplant, there's a high mortality. So do you have any sense of post-transplant renal outcomes, mortality, CKD, kidney transplant?
So this is an excellent point. And actually, we do not have currently any prospective data. The only data which I could find in the context of HRS AKI, non-responders versus responders taken up for a liver transplant. And the group from Paolo Angeli had shown that almost 20% of the patients required renal replacement versus 0%. So HRS non-response, not on renal replacement. There also kidney, whatever is there in the pre-transplant does determine, and CKD developed in almost 46% versus the other group where there was a HRS response to terlipressin. In the context of AKI, or we have earlier data where the data from Dr. Nadeem Mitra's group where they showed using the rifle criteria, the duration of CRRT and ATN outcomes versus, but again, with this setting, now that we're dealing with ACLF, the novel definitions that we have to see and do prospective studies looking at the kidney outcomes when patients are taken on renal replacement therapy, what type of therapy, duration of RRT before, in the context of ACLF. That will be very interesting to study. And the role of biomarkers in a non-oliguric patient, which patients will recover their kidney function, or upfront we should just go for SLK rather than going for a liver transplant, not getting a kidney and getting worse outcomes in the post-transplant.
Yeah, it's critical for the, transplant community in general to generate this data because, of course, we do now have strict criteria for kidney allocation, but prior to that, there was an argument with any degree of renal insufficiency, acute or chronic, we might be better off doing simultaneous liver kidney up front rather than taking them into transplant liver alone and then see what happened, because simultaneous liver kidney definitely has a better outcome than liver alone followed by tandem kidney. And if you don't get a kidney, we have shown mortality is very high. They develop infections and die. So something that we need to really generate as we move forward for us to come up with some reasonable data to guide us as to what we should do.
I think this is a really interesting point, isn't it? And, you know, transplantation we see as the sort of nirvana, we've solved it. But in fact, it's the post-transplant course, both in terms of renal dysfunction and other cardiovascular morbidity, that we also really need to look at. And I think it's even for those that don't get transplanted, who have an episode of AKI, renal replacement therapy, get out of the ITU, we are not good at following them up in terms of what their chronic insult is following an acute insult. both in terms of renal and other cardiovascular and neurological deficits. So I think loads of great work to be done in this field. Seems like a randomized controlled trial to me coming down the line. Any questions from the floor?
I just want to add one point. Yeah. So I'm an nephrologist, basically. So this is like this, that when we were talking about recovery from acute kidney injury in the sepsis setting, so not only the urine output we are looking at, but what obviously the biomarkers will be helpful, but it is not yet bench to bedside. Clinically, it is not available yet. But what we can do, and I think the evidence also suggests that we can do a dynamic kidney function monitoring during the recovery process. When you have urine output which is around 400 to 500 ml, you can just monitor the dynamic kidney monitoring. You can utilize the urinary urea and creatinine, and then decide how is the recovery process going on day-to-day basis. And then you can switch over from CRRT to SLADE, or you can stop SLADE also sometimes. So that is my thought process at this moment.
I agree, sir. I think, but I'd be also interested in, how do you think we might assess renal function when you're on a filter, when you're oligoanuric, and perhaps your urine output is only 200 mils an hour? And many of us would say, should we be removing the urinary catheter because of sepsis-related concerns? Do you think any of the biomarkers are useful in that context?
Biomarkers?
Any of the biomarkers from the various renal sepsis studies?
Urinary biomarkers, what we have till this period of time, the several, you can say that from KIM1, NGAL to LFBP, all those things. But what is important here is these biomarkers are released from different parts of the tubule. So if one part of the tubule, let us say that distal converted tubule is involved, then proximal converted tubule biomarkers, if you take into account, it will not show anything. So it has to be a biomarker, what we can say, a lot of biomarkers which has to be analyzed, and it is not a human being which can reduce that. I think the artificial intelligence and machine learning process will be much more essential in that, reducing whether it is really producing the difference or not.
Super, thank you.
Thank you, dear experts, speakers, and panelists.